Welcome to your meeting with ICM. The interpretation button should appear at the bottom of your screen, next to the Share Screen button. By clicking on the interpretation button, you can choose the language you would like to hear. The interpretation button will then transform this meeting into the selected language. To change the language you would like to hear again, follow the previous procedure by clicking on that same button. By default, you will hear the selected language at 80% volume and the original audio at 20% volume. If you would like to mute or unmute the original audio, click on the corresponding option within the language button. Enjoy your meeting. Bienvenue à votre réunion avec l'ICM. Comme la réunion propose une interprétation simultanée en français, le bouton Interprétation devrait apparaître en bas de votre écran à côté du bouton Partager l'écran. En cliquant sur le bouton Interprétation, vous pouvez choisir la langue que vous souhaitez entendre. Le bouton Interprétation se transforme alors en la langue sélectionnée. Pour changer à nouveau la langue que vous souhaitez entendre, suivez la procédure précédente en cliquant sur le même bouton. Par défaut, vous entendrez la langue sélectionnée à 80% de volume et l'audio original à 20% de volume. Si vous souhaitez couper ou supprimer l'audio original, cliquez sur l'option correspondante dans le bouton de la langue. Bonne réunion. Bienvenido a su reunión de la ICM. Como la reunión ofrece interpretación simultánea en español, el botón Interpretación debería aparecer en la parte inferior de su pantalla, junto al botón Compartir pantalla. Haciendo clic en el botón Interpretación, puede elegir el idioma que desea escuchar. El botón Interpretación cambia entonces al idioma seleccionado. Para volver a cambiar el idioma que desea escuchar, siga el procedimiento anterior pulsando el mismo botón. Por defecto, oirás el idioma seleccionado a un 80% de volumen y el audio original a un 20%. Si quieres silenciar o desilenciar el audio original, haz clic en la opción correspondiente del botón de idioma. Disfruta de su reunión.
Welcome, everyone. You can engage in the session through the chat box. And for any questions you have, feel free to use the Q&A button in the bottom of your screen. We will address those questions at the end of the session. Now I'm going to hand over to Mandy. Just 1 second. I'm going to share my screen again.
Morning, good afternoon, and good evening, and thank you so much for joining with us today as we go through this series of webinars. Today is the first of a series of 5, and we're going to be talking about the global overview of midwife-led birthing centres in low and middle-income countries. I'm Mandy Forrester. I'm one of the midwife advisors at ICM, and I was a member of the technical working group for this project. I just want to talk through today's session. We're going to talk about the introduction to the project, give an overview of the webinar series. We're going to have a couple of poll questions just so that we know what's going on out there with you in your areas. We're going to talk about which low and middle income countries have midwife-led birth centres and what their main characteristics are. We're going to be talking about how we use the Network of Care framework to map enablers and challenges to establishing successful midwife-led birth centres. And then we'll finish with a Q&A. I just want to say that the slides are only in English, but we will speak to everything on the slide, and we're going to endeavour to speak slowly so that the interpreters can make sure that you're well aware of what we're saying. So before we start, there's a few definitions that we need to really nail down. So what do we mean when we talk about midwife-led? We mean the midwife is the lead healthcare professional. The midwife is responsible and accountable for planning, organisation and providing care. And this is care that is not provided under the direction of a doctor. A birthing centre is a dedicated space offering childbirth care. Now, a midwife-led birth centre may be part of, next to, or completely separate from an obstetric unit. When we talk about the midwifery model of care, we're talking about a model of care that is rights-based. It's respectful care that supports the physiological birth processes where this is the safest option. And it's a model of care where midwives work in partnership with the woman and other healthcare professionals. So why is ICM advocating for midwife-led birth centres in lower middle-income countries? Well, we know that midwives are essential providers of primary health care who can save lives and improve health outcomes. There's strong evidence of the benefits of midwife-led care in high-income countries, but less so for low and middle-income countries, where, as you know, the most mortality and morbidity occurs. So more evidence is needed about the feasibility of this model care in lower middle-income countries to inform efforts to scale it up. Secondly, midwife-led birth centres align with global and national priorities. So when we think about midwife-led care, as I've said, midwives save lives, and for uncomplicated pregnancies, they avert the complications associated with medical models of care. Midwife-led care is woman-centred. It's a right-based model of care. And in midwife-led care, there is also continuity of care, where we know the evidence strongly supports. It's not just the midwife-led care, but it's primary healthcare priorities that MLBCs also support. Because in primary healthcare, we would like care to be provided close to communities. And when we think about universal healthcare coverage, midwife-led birth centres improve access to quality care. So the objective of this work was to provide evidence to support the scaling of midwife-led birth centres in lower middle-income countries. And the aims were twofold. We wanted to identify where MLBCs have been established, and we also wanted to understand what needs to be in place for them to be successful. The research team included Dr. Andrea Nova from Novometrics and Professor Caroline Homer from Burnet Institute in Australia, and they were supported by leads from the 4 case study countries, and we'll be talking about those countries further along in the series. The work was also supported by ICM, by funding from Bill and Melinda Gates Foundation. We received technical support from UNFPA and technical guidance from an expert advisory group, most of whom had either worked in birth centres, researched birth centres, or were particularly interested in the topic. I'm now going to hand you over to Professor Caroline Homer, who's going to give an overview of this webinar series.
Thanks very much, Mandy, and a very warm welcome to everybody joining from all over the world. And it's lovely to see the different places in the chat that I'm seeing. Thank you for sharing where you're from. So I'm going to give an overview of the series. We have 5 webinars in this series. We'll just go to the next slide. Today, as Mandy said, we're doing an overview of the initial work that was done to start the series. And then on the 24th of October, we're going to look at our 4 case study countries. This is Bangladesh, Pakistan, Uganda, and South Africa, and look at what is needed for success. We're going to look at the financing model and the supportive and enabling leadership and governance. The week after, we're going to look again at those 4 countries, but this time look at the quality care that is recognised by the community and the interdisciplinary collaboration, coordination, and functional referral systems. We've broken up the case studies into 2 sessions because there's a lot to get through, and we felt it was much more useful to go in depth in these 4 issues. In early November, we're going to talk about the costing of midwife-led birth centres, and this is really important. And then the last webinar, so we miss 1 week, and then the 21st of November, we're going to talk about scaling up MLBCs. What will it take? What do we need to know from the evidence? Thank you. So a lot of you are writing in the chat already about whether midwife-led birth centres exist in your country, but we just want to do a very quick poll. So Bruno will just put up the little poll. Some of you may have done this before. So we just want you to click on yes, no, I don't know, or I don't know what an MLBC is, which is fine because you're here at a session about MLBCs. So I'll just give you half a minute to click on one of those options. Great, thanks, Bruna. We have lots of countries with MLBCs, lots of participants with MLBCs in their countries, almost 2/3. So that's really exciting for us. That shows that this is an area of lots of interest with lots of opportunities. But we also have 1/4 that don't have MLBCs. So again, a wonderful opportunity. We'll go to the next poll now. We only have 2 polls. So we're interested in whether you would like to work in a midwife-led birth centre. So you either already do, and that's probably many of you, or you would like to, or you don't want to, or you're not sure. So let's just do this second quiz. Hopefully you're seeing how to do that on the poll screen. Maybe for some of you, if you're on a phone, it's a bit harder. But let's see the results. So about 1/4 of you already do, but more than a half, almost 2/3 of you would like to work in one. So that's really interesting and really exciting, really, and shows that this webinar is going to be really useful. So I'm going to now hand over to Andrea, who's going to take us through our first scoping review that looked at where are the MLBCs and what are their characteristics. Over to you, Andrea.
Thank you, Caroline, and good morning, good afternoon, good evening to everybody. It's a great pleasure to be here. Next slide, please, Bruna. Before I start to talk about the initial scoping review and scoping survey, I just want to let you know that there are already 2 peer-reviewed publications available, which give a lot more detail on what we're going to talk about today. You can see those on the screen, and there are QR codes you can use to get easy access to those 2 papers. One was in midwifery, and that covered the section of the webinar that I'm going to talk about this morning. And the second was in the PLOS Global Public Health, and that covers the material that Sabra will tell you about a little later. Next slide, please. So in today's webinar, we are aiming to provide at least partial answers to 4 research questions. Firstly, in which low and middle income countries do MLBCs exist? Second, what are the main characteristics of midwife-led birthing centres in low and middle income countries? And a little bit about what they have in common with high income countries and what is different between high income and low and middle income countries. The third research question is, what is the impact of midwife-led birthing centres in low and middle income countries? And how have researchers measured or evaluated that impact? I will aim to answer those first 3 questions in bold, and then the 4th question, what are the enablers and challenges to implementation and scaling? That 4th question Sabra will address. Next slide. Very quick summary of what we did in this initial global scoping review and scoping survey. There were 3 elements to this part of the research. Firstly, we looked at the peer-reviewed literature to see what that could tell us about which low and middle income countries have midwife-led birthing centres. We searched 9 academic databases. We screened nearly 8,000 papers. It was a big job. And we found 55 that met our inclusion criteria. We were very conscious that the peer-reviewed literature didn't give a complete picture of what's going on in this sphere. So we also looked at the grey literature. We looked at web pages, blogs, published reports, etc. And we found an additional 46 items. So we had a total of 101 papers or other items of literature that talked about midwife-led birthing centres. And to supplement the literature, we did the 3rd element, which was an online survey of midwives associations and UNFPA offices. Out of the 137 low and middle income countries in the world, 77 very kindly completed a survey. So I'd like to just place on record our gratitude to you if you were one of the people who contributed to that survey, because it really added a lot of rich information to what we found in the literature. So thank you. Next slide. So for the literature, we had a number of inclusion criteria. So in order to be included in our 101 pieces of literature, the item had to describe a health facility which provided childbirth care. And that care had to be provided by midwives or nurse midwives as they were defined in that country. There had to be evidence that in that health facility, there was a clear commitment to the midwifery model of care. As I'm sure most people on this call are aware, there are many health facilities around the world where midwives are really the only available health workers. So they are sort of midwife-led in the sense that the midwife is in charge. But if there's no clear commitment to that midwifery model of care, then that was not counted as a midwife-led birthing centre. Obviously, we're only interested in this piece of research in low and middle income countries. We looked at literature that was published in English or French or Spanish between the years 2012 and 2022. And we didn't place any limits on the type of literature, except that we excluded other literature reviews because we didn't just want to repeat what people had done earlier. Next slide. So, in answer to our first question, well, where are these midwife-led birthing centres? And this is a graph which explains the answer that we found to that question. So according to the literature and the survey, there are 57 low and middle income countries out of 137, which showed at least some evidence that midwife-led birthing centres exist in that country. And you can see on this graph how those 57 countries are distributed around the world. So on the left-hand side, we can see how they are distributed according to ICM region. So out of those 57 countries, 20 are in Africa, 9 are in the Americas, 10 are in the Eastern Mediterranean region, 5 are in Europe, 7 are in Southeast Asia, and 6 are in the Western Pacific. On the right-hand side, you can see how they are distributed according to the country's income group. So 15 of the 57 are upper middle income countries, 26 are lower middle income countries, and 16 are low income countries. You can also see that each of the bars is divided into 2 shades of colour, and that is because some of the evidence was stronger than other pieces of evidence. So if you remember, I explained that we did 3 different strands to this research. There was the grey literature, the peer-reviewed literature, and the survey. And if a country showed up in at least 2 of those 3 strands, then we counted that as strong evidence. And that's the darker shade at the bottom of the bar. So of the 20 countries in Africa, 9 of them had strong evidence. Next slide. And you can see here listed those 24 countries where we felt the evidence was strong. So in the upper middle income group on the left, we have Brazil, Ecuador, Fiji, Guatemala, Mexico, and South Africa. In the lower middle income group, we have Bangladesh, Ghana, Haiti, India, Indonesia, Iran, Morocco, Pakistan, Philippines, Zambia, and Zimbabwe. And in the low income group, we have Afghanistan, Gambia, Guinea, Malawi, Sierra Leone, Uganda, and Yemen. And we've highlighted in bold type on that list the countries that appeared in the peer-reviewed literature. And we were very interested to note that only relatively few countries on this list of 24 feature in the peer-reviewed literature, and that's particularly true in the low-income countries. The evidence from the low-income countries came from the grey literature and the survey more so than the peer-reviewed literature. Next slide. We also looked at what the literature had to say about what the characteristics are of these midwife-led birthing centres in low and middle-income countries. So we found that in most of those 24 countries with strong evidence, they usually had midwife-led birthing centres in both urban areas and rural areas. All 24 of those countries had evidence of freestanding birthing centres. Now, by freestanding, we mean that the centre was on a completely separate site to the nearest hospital maternity unit. Half of the 24 countries had on-site centres, so that was where the centre is in the same building as the hospital obstetric unit. And a few countries had what we called alongside birthing centres. So that's where the birthing centre is on the same site as the main hospital obstetric unit, but a little bit separate. It's not in the same building necessarily. In most of the 24 countries, the centres offered, in addition to childbirth care, they offered antenatal and postnatal care. Over half of the 24 countries had birthing centres in both the public sector and the private sector. 3 countries only had public sector birth centres and 6 only had private sector, according to the literature. I should add as a caveat there, it may be that there were others that we didn't read about in the literature. And we found it was this varied a lot according to the income group of the country. So low income countries were largely dependent on private sector, not-for-profit birthing centres. And the private for-profit birthing centres were more commonly found in upper middle income countries, as you might expect. We also looked at the extent to which the centres were integrated into the national health system. And we found that in 2 of the upper middle income countries, Brazil and South Africa, there was very strong integration. The birthing centres were very much part of the larger health system. But in the other countries, there was a mix. Some countries had some birthing centres that were well integrated and others were a little bit separate, a bit more independent. Next slide. Now, we also looked at how successful or how the quality of care that was on offer in the midwife-led birthing centres. And we found that this was very often quite difficult to measure, and a lot of pieces of literature didn't even try. But the ones that did try to measure the impact usually did it via a retrospective analysis of health facility records. And there was an attempt very often to compare the outcomes from the midwife-led birthing centre with public sector hospital obstetric units. However, those comparisons were very often methodologically flawed. They found it very difficult to take into account the fact that the clients of the birthing centre were often quite different to the clients of the hospital obstetric unit, and it wasn't always easy to take into account those differences. However, several studies did try to look at that, and they tended to report low mortality and morbidity rates, low intervention rates, and high quality of care. So the outcomes were generally found to be good in the midwife-led birthing centres in low and middle income countries. A couple of exceptions we found in the literature. There were 1 or 2 papers that discussed that the existence of disrespect and abuse in midwife-led centres in South Africa, and 1 or 2 papers from Brazil that assessed the extent to which the midwives were adhering to evidence-based practice, and found 1 or 2 examples where there were potentially harmful practices going on in midwife-led birthing centres. Next slide. So now I'm going to hand you over to Sabra, who will take you through the second half. Thank you.
Good morning, good afternoon, and good evening to all of you across the world. I'm going to take you through the results of our scoping review, which is using a network of care framework and map out the enablers and challenges for establishment of a successful MLBC in low middle income country. Next, please. Of course, our research question is that what are the challenges and enablers to establishment of and scaling up of MLBC in low middle income countries? Next, please. Before we moving on, I'm going to give you a definition of network of care and also going through the framework which we used for this study. A network of care is a group of public and private health service deliveries that are deliberately interconnected and through an administrative and clinical management model that promote client-centered approach in an enabling environment, with adequate resources and encouraging collaboration across all levels of care, including community engagement. The positive impact of network of care reinforce collaboration and relationship across service delivery. The key element of a safe, high quality, and effective MLBC is to work within a well-functioned network of care. And of course, while we're talking about quality of care, quality starts with the performance of individual providers, but sustaining such high quality of care require a multifaceted support system, which is known as network of care. There are many types of ways to present network of care, and there are many types of framework if you go across literature. But for this study, we used the scoping review adapted from Carmen et al. 2020, which you have access to. And that framework categorized network of care in 4 main domains, as you can see in the image, including enabling environment, operational standards, quality efficiency, and learning and adaptation, which each one has its own subdomains. But keep in mind, as we go ahead with the finding of this study, and you reflect in your context, self-reflect on your context, make sure that you know that these 4 domains are interrelated. And for example, without a strong policy enforcement and adequate competent workforce and supplies, it's not possible to implement quality of care and develop trusting relationship. Next, please. Yes, we did a thematic analysis, our finding under these 4 domains, which I'm going to talk one by one in the next few slides, and yeah, talk about all the themes and sub-themes. Next. Yes, as Andrea mentioned, same way we reviewed hundreds of papers and we ended up to shortlist 4 these studies, which was focused in our research area and which representing 12 countries, as you can see in this list, and they are from upper middle to lower and low middle income countries, in total 12 countries. So now I'm going to take you one by one for each domain and briefly explain the findings, and please reflect in your context, how does it look like for you? Next, please. The first domain is agreement and enabling environment. Our findings indicate that a strong policy environment was essential for working collaboratively within a strong network of care. The policy-related issues and factors can enable or restrict midwifery-led centers to collaborate with other parts of the health system. For example, government policies in Brazil facilitated MLBC integration within health system and improved performance autonomy of health providers and offered services which is more fit for purpose and client-centric. strategies such as establishment of health insurance and incentivized services, fee waivers for maternity services were used to make services more affordable and to increase service utilization. In Mexico, midwifery is not well recognized within government policy, and that also impacted negatively the service utilization within MLBCs. Then, with the cost and financing issue, when the government in the place or context which we reviewed, that lower the fees or there is a free services, it improved equity of access, but actually it is very context-based. In contexts such as Bangladesh, as you can see in the slide, the committee perceived that the lower fee or no fee means lower quality, and then they didn't utilize service adequately. In some countries, the only way women can get access to social welfare was through the institutional delivery at big tertiary hospitals. And therefore, MLBC might not be an option for those women, and they didn't utilize services. Anyway, on the demand side, women feel that where there is a strong network of care, the MLBCs are more responsive to their needs, and they tend to utilize services more frequently and adequately. It means they trusted the services. Overall, our study showed that continuity of care, positive communication, informed decision-making, and context-based and non-medicalized approach were critical elements for buying and trusting relationship. Approachability and presence of healthcare providers and interaction with the known midwives was highlighted as the strong features of midwifery-led care. Next, please. So coming to the second domain, we highlighted the operational standards that are required for a functional network of care, which include referral system, monitoring evaluation, adequate supplies and infrastructure, and competent workforce. The integration of MLBC within the established referral system improved the confidence and sense of safety among both providers and service users. In the other hand, the lack of integration of MLBCs in health system make it very difficult for health providers to navigate ways that they can refer women somewhere to receive adequate care. And this may reduce the timely management of emergency cases. In all of the settings which we reviewed the studies, some sorts of referral system were available, but unfortunately, in most cases, it was not functional due to lack of, for example, transportation or broken ambulance, lack of equipment, or geographical challenges. A data recording and reporting system for tracking MLBC's performance and improving quality through the regular monitoring was mentioned in few studies, but we didn't find strong evidence on that within the papers which we reviewed. Only 3 studies referred to processes such as organizational audit, monitoring, and benchmarking briefly. In Iran, for example, there was no integrated monitoring system within MLBCs, and they used their unofficial, like hard copies of books to record, and it doesn't go anywhere. It just stays within that MLBC. It's not connected to the central level. In Brazil, just after the case of implementing MLBC services, just recently they decided to the government decided to establish a management system that improve access, improve the data system, and monitor the safety of MLBC services. Anyway, coming to supplies, inadequate supplies and infrastructure make it very challenging for MLBC to operate efficiently. In South Africa, poor infrastructure means lack of privacy and quality of care. In Bangladesh, social barriers and gender inequality contributed to lack of supplies and lack of supplies because the local authorities prioritize other services rather than MLBC services. Lack of medication, supplies, and modern technology caused women to avoid MLBC services in contexts like Nepal. So The workforce challenges tend to be the biggest barrier for effective functioning MLBCs. Key bottlenecks include lack of midwifery shortage, workforce shortage, excessive workload, lack of clinical competence, and professional development opportunity, and lack of autonomy for midwives. Next, please. Going to the domain 3 that encompasses quality of care and efficiency of care delivery, our key finding shows that frontline health worker leadership is keystone to this domain. The importance of teamwork and coordination of care was highlighted across many, many papers. Coordination of care through communication, networking, partnership, and interprofessional collaboration were identified as an integral part of MLBCs. In some contexts where MLBC are not well integrated within network of care and health system, coordination includes providing information to women regarding the steps required for emergency situation, because there is no system in place and they need to find their way. Actually, this study which we reviewed that showed that this kind of exchange of and collaboration with women also reduced the delays in seeking help. That means women at least get some information to find their way through the system. Anyway, in private MLBCs in Pakistan, for example, midwives have very limited opportunity to collaborate with midwives or other healthcare professionals outside their institution, and that also led to poor quality of care due to isolation and lack of monitoring. In Mexico, where MLBCs are not part of health system, some evidence showed that a network of providers with women organizations work together collaboratively to increase access of women to midwifery model of care through MLBCs, which was really good. Studies also indicate barriers and facilitators in use of guidelines and delivering evidence-based practice. Our study shows that the places where implementing the guidelines properly, they prevent complication and unnecessary interventions. MLBC in Mexico had positive experience with producing their own guideline, adopted from international guidelines and tailored to their own needs, and that also improved the quality of care in their context. In a few settings, engagement of healthcare providers in development of clinical guidelines and standards improved compliance with clinical guidelines and also strengthened the referral system. Supporting supervision and mentoring with further capacity building improved clinical competence and confidence of health providers in management of high-risk patients. So overall, a lack of commitment among midwifery members of the network of care, and also clashes between the members of network of care, lack of infrastructure, and lack of awareness of community about MLBC services sometimes was considered as barriers towards implementing evidence-based practices. Thank you. Next, please. So the final domain, which is domain 4, highlighted the value of learning and adaptation to sustain effective MLBCs. This includes being woman-centered, being flexible, and extending reach to those in need, using up-to-date technology and innovative approach. Different aspects of client-centered care, such as safety, autonomy, and shared decision-making, enabled MLBCs in many contexts to fulfill the cultural and individual needs of the community, especially those underserved and vulnerable groups. The MLBC environment provides a safe space to maximize women's privacy and trust on their care providers. And also, even in the settings with restrictive gender norms, such as Bangladesh, Iran, in some countries like that, they even encourage labor and birth companion, which is really give women a sense of safety in their environment. In Mexico, women who had experience of domestic violence, they found MLBC as a safe place to seek help and raise their concern when they need it. Women from Bangladesh, Pakistan, Iran strongly acknowledge the presence of a female provider, which give them a sense of trust and confidence in MLBC services. And they also appreciate respecting their values and privacies during care. In South Africa, however, sometimes the midwives find it very challenging to provide privacy and make room for implementing policies due to other resource limitations, which affect the quality of care adversely. So in places where midwifery-led birthing centers established alongside tertiary hospitals or facilities, women had better access to emergency obstetric and newborn care and management of complications. In Brazil, the location of MLBC attract more women from low socioeconomic and disadvantaged background to use public health services with lower cost. Conversely, in Sierra Leone, which MLBC is mostly funded by donors and located in capital cities, it made it very inaccessible to the rural and poor population. So in terms of use of technology, innovative use of technology, we find limited information across literature which we reviewed, but a couple of papers addressed issues such as non-medicalized complementary methods such as acupuncture and aromatherapy and mindfulness as a way to improve satisfaction with their services. That's all from me, and I think as we went through those slides, I hope you get some of these things, which is very common in many contexts, but some of them are really specific to some contexts. And I hope you reflect on that and you come to a self-reflection on how to improve those things. I'm going to hand over to Andrea, and thank you for listening.
Thank you, Sabra. So I'm just going to very quickly draw together a few conclusions from both my section of the talk and Sabra's section of the talk. So firstly, I think it's clear that the peer-reviewed literature does not provide a comprehensive picture of the low and middle income countries in which midwife-led birthing centres exist. In the grey literature and in the survey, we found many additional countries that do not feature in the peer-reviewed literature, which we thought was a very interesting and important finding. Looking at the evidence in the literature, we found a very clear evidence gap, two gaps actually. One was relating to measuring the impact of midwife-led birthing centres in low and middle income countries, particularly comparing that to other models of care that may be available in that country. We don't really know how good the care and how good the user experience is in comparison to other options in many countries. We also found very little information about how midwife-led birthing centres are financed in the literature. We will be looking at that in more detail in next week's session, looking at our case study countries. But as far as the literature is concerned, there's very little information about that. As Sabra mentioned, many of our findings actually echo those from research about midwife-led birthing centres in high-income countries. For example, we found examples of professional hierarchies and rivalries which can make things difficult. We found evidence that midwives who are trained under a medical model of care are very often not confident to lead and work within a midwifery model of care. That applies both in high-income countries and low and middle-income countries. However, we did find one or two findings that we felt were more specific to lower and middle-income countries and a bit different to what research has found in high-income countries. And that might have implications for scaling up this model of care. For example, as Sabra mentioned, in many countries, the midwife-led birthing centres are serving less wealthy women, poorer women, whereas in high-income countries, it tends to be the more wealthy women that access that model of care. We were very interested in the findings as they related to freestanding midwife-led birthing centres, those that are on a separate site from the hospital. The research from high-income countries indicates that outcomes are better in those freestanding midwife-led birthing centres, whereas in many low and middle-income countries, the referral systems are somewhat weaker, which makes it a bit more risky perhaps to give birth in a freestanding midwife-led birthing centre. Next slide. But we did find, I think, very strong evidence from the literature and the survey that midwife-led birthing centres can provide high quality care, particularly when the network of care elements are in place, i.e. a positive policy environment, purposeful arrangements which ensure that services are responsive to the needs of their users, an effective referral system which enables collaboration across the different levels of the health service, and a competent workforce that is committed to the midwifery philosophy of care. There was also very clear evidence from the literature that there are challenges to an effective network of care, and the strongest themes that came out of the literature here were a lack of supportive policies, a lack of supportive leadership, interfacility and interprofessional collaboration that didn't always work very well, and of course insufficient financing. So we felt that the network of care framework was actually quite a useful approach to identify the key areas that need addressing in terms of collaboration, consultation and referral, addressing the specific local needs of the women in that catchment area and their families, and to identify areas for improvement in health services. Next slide. So now we have talked for long enough. We'd like now to hear a bit more from you. There are a few questions that have already come into the Q&A, which I think Caroline has been answering. So if you are looking for the answers to those, have a look in the Q&A box. But I would like to invite you, if you haven't already, to contribute in the Q&A or the chat to tell us what you think. You don't have to limit yourself to these questions, but we thought they might stimulate some discussion. So, for example, you've listened to us talk. Does what we have said align with what you know about MLBCs in your country? And we're talking specifically here to our participants from low and middle income countries, but we're also very happy to hear reflections from our colleagues in high income countries. Secondly, based on your knowledge and experience, what do you think we missed? Did we miss anything? Would you like to add anything? Is there more to say on any of the topics that we have discussed today? And thirdly, which elements of these findings do you think are particularly important in your country or in your workplace? So, Mandy and Caroline, in terms of what's come up so far, are there any questions or observations that you would like to share?
I think one of the observations that's a very good one, Andrea, is that in countries where midwives are not valued, it's very difficult to set up and sustain midwife-led birth centres. If there's a strong obstetric model of care, it's very difficult for midwives to then have their own centres. And I think we've seen that. Sabra mentioned that as well in the network of care. So one of the really important areas is to strengthen midwifery in your country, to work with your government in terms of strengthening policy, strengthening the guidance that supports midwifery, and importantly, making sure that the midwives are really well educated. So they're educated to ICM global standards, and they then, the argument then can't be that they're not good enough, and so women need doctors. So if you have strong midwives, strong education, strong regulation, and strong support through your professional association, your chances of getting midwifery in policy go up. And then you can develop your MLBCs. But you sort of can't wait for everything to be perfect as well. You sort of have to have a go, even if everything isn't perfect. And I think that the 16 MLBCs that you will hear about in the rest of the webinars really tried to get going and to be sustainable without being perfect. So I hope you'll get a lot out of the particularly next 2 weeks.
And from the chat, it's very interesting to see a few people have actually said that they're working already with MLBCs and have got data and outcomes that they'd like to share with us. And I'm just wondering, panel, team, colleagues, which is the best way for people to do that, because it would be helpful to hear those outcomes, etc. So that's something that we need to take back as a team and think about. And the other thing is everybody's putting their WhatsApp numbers and email addresses in the chat. Did somebody in the chat say that they would be collecting this to put people in touch with each other? I must have missed that. I'm not clear.
Thank you, Mandy and Caroline. Yes, for those who are putting their email addresses in the chat, I hope it's not something that ICM is planning to do, I don't think, Mandy, but if someone is planning to collect all of those and create a community of discussion or practice, is that what's happening?
It looks like that's what's happening, yes. It's a common wish for everyone to keep in touch, but like Danielle has just said, at the moment, ICM aren't planning to do that.
Okay. So please, if you're looking at the chat, then help yourself to the email addresses that are being shared, because these are people who want to keep this conversation going, I think.
Andrea, the other network that might be useful, and I've put it in the Q&A, is the wonderful Good Birth Network.
Yeah.
So if you go onto the Q&A, the Good Birth Network is particularly set up. It's a global network of midwifery centres providing safe and respectful care to women and families. I'm just reading off their website. And it's particularly focused on low and middle income countries. So it's a fantastic resource as well for you. There's also the WHO Community of Practice for Nursing and Midwifery, and we can find that link for you as well. But the WHO Community of Practice is also a place that you can share your experiences and find like-minded people to work with and to help you. So there are lots of resources out there. We just have to find them all.
Caroline, I don't know if you've noticed, I've seen in the chat a couple of people saying that there is legislation or regulatory restrictions in their country which prevent the establishment of midwife-led centres. I don't know if there's anything you want to say about that.
Look, I think it's a process in many countries, and it's about advocacy, using the evidence. It's a hard journey. I won't deny that it's easy. But you know, small steps and whatever you can do to gather support from others, but I think particularly using the evidence. And we know now we've got costing evidence, we've got State of the World's midwifery evidence, we've got Lancet series evidence, but politics is hard and it's slow, and you have to get together, and that's why ICM is a good, you know, your midwifery association, who are supported by ICM, obviously is very important.
And I think I'd like to add to that in saying that ICM is currently revising and updating anything pertaining to the regulation of midwives. So the global standards will be refreshed, and the toolkit to help MAs and regulators work towards more effective midwifery regulation is ongoing as well. So there will be an update of processes to help you work towards regulation of midwives. Echoing what Caroline has just said, though, it's a very slow process, and it's something that needs a lot of advocacy and a lot of commitment. Brilliant when it gets there.
I can see there's a message in the chat there from Jen Stevens.
Oh, brilliant.
Oh, great.
Just saying thanks for sharing the
I hope
information about the Good Birth Network.
I hope she doesn't mind.
No, she seems happy. But she does say that if you are from a country which has restrictive regulations or legislation, then she would love to hear from you. She's put her email address in the chat box. So just to draw attention to that.
So great to have Jen with us. I'm just typing into the chat the global, it's called the Global Community of Practice. And I'll put it in the chat as well, just might be easier for some people. This is the WHO
Yes, I
global
think
community of practice.
Sheila shared that as well. Sheila Close
Ah,
shared that as
lovely.
well. So yeah, there are 2 links to that in the
Sorry,
chat
I'm
box.
running two things here.
You've got lots of plates spinning at the same time. You're doing well. Okay, so unless I'm not seeing any more big issues coming up in the chat. So
No.
Bruna, before you stop the presentation, can I ask you just to move forward 2 slides, please? I just want to flag up, Caroline's already mentioned this, but in case anyone wasn't able to be with us right at the very beginning, we do have 4 more webinars coming up to really explore this topic in a lot of detail. So next week, we are going to start to hear from our 4 case study countries, Bangladesh, Pakistan, South Africa and Uganda. We'll have a speaker over the next 2 weeks. We will have a speaker from all 4 of those countries sharing insights from their work. They looked, each of the 4 countries looked at 4 specific sites. So we have 16 midwife-led birthing centres in total with which to share experience with you. And just as a sort of quick teaser, I think to summarise what we found, context matters. You can't just drop a midwife-led birthing centre that was designed for one context into a different context. However, we do feel like we have identified some universal patterns, some universal enablers and challenges. So we'd like to share those with you in particular across the next 2 sessions. And we very much look forward to seeing you again next week. Thank you, everyone. Does any of the other panelists wish to quickly say anything, or shall we leave it there?
No, that's brilliant. Lovely to have all of you with us on this webinar, and we really look forward to next week.
And thank you, everyone. And a network of care is important for implementing a good, high-quality midwifery-led care.
Top takeaway. Thank you. Bye, everyone.
And
Bye, everybody.
if anyone has any questions, you can contact us on the following
Yeah.
emails.
Thank you, Bruna.